So this is Dr. Karpiak again. I'm going to introduce the last section of this effort today. I must say I'm very, very encouraged by hearing the voices of so many people with such a diverse background. It's truly amazing. The next two folks who are going to speak are Dr. Anjali Sharma and Dr. Tonya Taylor. I know both of these women very, very well. And by the way, I hope you've noticed how many women we've scheduled into this webinar. They are not to be forgotten and never should. I'm going to introduce both of them and let them take the ball from there. Dr. Anjali Sharma is an associate professor at the Albert Einstein College of Medicine. Dr. Sharma is a principal investigator on the NIH Max Weiss combined cohort study, which is also has a site at Albert Einstein up in the Bronx. Her research and clinical practice focuses on the too often forgotten challenges of getting HIV, forgotten women with HIV, especially older women. She has faced the challenges of getting HIV treating physicians to embrace geriatric care principles. Each time I have had an opportunity to speak with Anjali, I feel as if I am in the presence of a powerful intellect wrapped with compassion. Next, we'll have after her, Dr. Taylor. Dr. Taylor is on faculty at SUNY Downstate Medical. I collaborated with her on multiple research efforts, all of which focus on women, especially older women with HIV. Her passion for the lives of those living with aging with HIV began after her 10 years of research done in Africa. She would later achieve an NIH Career Development Award. She is a colleague and a friend. Both of these women are. Please welcome them and listen to their experiences. Thank you.
So much. Should I go first?
Yes, please.
Yes.
Great. I'm going to share my screen. All right. Can everybody see that? I put into the...
Yep.
Yes. Okay, great. Okay, so I'm going to talk today about clinical models of care for older people living with HIV. I'm not going to spend a lot of time on this slide because I think this is data we all know. We all know that people are living longer with HIV, and there's growing numbers of people in their 60s and 70s and now 80s across the entire world who are living with HIV. And in general, as people age, they do accumulate medical comorbidities, but this is particularly true for people aging with HIV. And along with the medical comorbidities, we also see issues of loneliness and depression, difficulty accessing services. And of course, we've had a lot of discussions today about stigma and intersecting stigma, including ageism, racism, homophobia, and more. So at this point, it's not really just about the comorbidities, whether psychiatric or medical, but also about the emergence of age-related conditions, such as geriatric syndromes. And some of the pictures here reflect some of the common geriatric syndromes that we're seeing in people with HIV as they age and at younger than expected ages. So for those of you who are not familiar with that term, these are clinical conditions that are very common among older people, and they cross disease categories. And oftentimes, individuals will experience a single symptom, like in the case of, for example, urinary incontinence, but there are many, many factors that lead to the development of that symptom and many different organ systems that are involved. So in this case, if a person, let's say, has a urinary tract infection, and then they get dehydrated, and they've been given a new medication, and that person had some underlying dementia, then what they might come in with is delirium. So that's just one symptom that they're coming in with, but there's so many different things that led to the development of that geriatric syndrome. And oftentimes there is some kind of acute event, an insult or an injury that leads to the geriatric syndrome being developed. developed, and then you see functional decline thereafter. So in the box, you see some examples of common geriatric syndromes that many of which we see frequently in people with HIV who are older. I want to just highlight the fact that comorbidities are not the same as frailty and disability. There is some overlap of these conditions, but they're distinct and sometimes related. So when we talk about disability, it's really the inability to carry out specific functions that are necessary to live independently in society. So there's a relationship between the person and society. And you can see on the left some of the basic activities of daily living, like being able to eat, like feed yourself, dress yourself, and then the higher order activities of daily living or instrumental activities of daily living, like managing to balance your checkbook or figure out transportation, throughout the city, for example, that are more difficult than the basic activities. And so when people have difficulties with these tasks, that leads to disability. And so this slide is really just to highlight that both of these individuals require a wheelchair, but you can see that the gentleman on the left is not frail. And the lady on the right is a frail older person. And so it's not just about, you may consider that there's a disability here, but that's not necessarily the same as frailty. And it's just an important distinction to make. And this slide just kind of highlights some of the ways in which we measure things like impairment and disability and frailty, for example. So when thinking about the needs of older people living with HIV, there's a number of challenges that are faced. On the one hand, oftentimes there's just too many people involved. There's too many doctors, there's too many specialists, there's too many appointments, there's too many medications and drugs. On the other hand, maybe not enough care or not the right kind of care. So for some people, if they're in an area where there is no specialty services, for example, that they need, they may not be able to access those resources. Or if there's inadequate transportation to get to appointments, underinsurance or high deductibles or copay, lack of health insurance, all of these lead to not enough care. But the other thing to think about is the fact that you may have enough care or enough access to care, but that care may be poorly integrated. So that means the primary care doesn't speak to the specialist, the specialist doesn't speak to the internist, the mental health doesn't speak to the medical health, and the medical setting is isolated from the community and from the home where people live. And I think that this issue of this growing need that we're going to see in the future as people reach their 70s and 80s for long-term care for older people with HIV cannot be underestimated and is sort of a looming specter on the horizon. So how might a geriatric approach help people aging with HIV? So geriatricians really focus on the 5 M's: mind, medications, multimorbidity, mobility, and what matters most. And this slide just kind of gives some examples of these key focus areas. So when we think about mind, that's not only just management and screening of cognitive impairment and dementia, but also things like depression and other mood disorders, delirium, other mental health conditions. Thinking about mobility, impaired gait and balance have been demonstrated in people with HIV, and there may be accelerated gait decline as people age with HIV. And then we've seen in our studies a high rate of falls in people living with HIV, which may actually disproportionately impact women as they age. Medications, as people accumulate more and more comorbidities, they often are prescribed more and more medications to treat each of these individual conditions. And what they're left with is really an unsustainable situation where the number of pills and the number of times a day and the number of restrictions with the medications becomes untenable. And oftentimes these medications may interact with each other and may carry their own risks, such as falls risk, for example. And then really thinking about what matters most, I think, I was listening very intently to hear about what are the areas that we don't pay enough attention to. And I actually think maybe this could be added to the list. really sitting down patients and providers together and having a conversation about what their goals are, not just for the short term, but for the long term, and making sure that the healthcare that we're providing and delivering or suggesting is aligned with those goals. So how do we do this? Well, one thing is we can think about ways in which we adapt our HIV practices. So an example here is upgrading provider skills in principles of aging, and that's really across all levels. Aging itself, the biology of aging, but also the types of conditions that are expected with age, and the kind that are not normal to be expected with age. What resources are available in the community, what aging stereotypes that we ourselves as providers may harbor, and the types of intersecting stigma, including ageism, that our patients are dealing with on a regular basis. I think it's important to blend our HIV-based and age-based community services and supports. I think to a large extent, these services have been siloed. And so to the extent that these linkages can be created, that would really serve older individuals with or without HIV. But really for welcoming spaces for LGBTQ seniors, racial and ethnic minority groups, and people living with HIV. And then the last is how to incorporate geriatric expertise into practice. And I'm going to talk about some of these examples, such as incorporating a comprehensive geriatric assessment, referring out to a geriatrician, or bringing a geriatrician into the clinic. So some of the models that are in use commonly right now include the Geriatric Consultation, which is probably the most common model of care. And this is where the HIV providers refer their patients out to aging specialists or geriatricians, or a team of providers that are skilled in age-related medical care. They can be embedded within the clinic, or they can be in their own geriatric practice. And then different programs have different referral criteria. Some use age 50, some use other medical criteria, such as a recent hospitalization or a fall or injury. It's quite variable. And then these geriatricians often then provide linkages to other community-based organizations and services and programs that they're aware of for people who are aging. I'm going to spend a little bit of time talking about the comprehensive geriatric assessment in a minute. So the metabolic clinics, I haven't really seen this done so much in the United States, but there are some examples in Europe for programs that really provide sort of hyper-specialized medical care for people who have lots of complex medical conditions that are increasingly now including age-related conditions in that fold, such as frailty and sarcopenia. So this is a table that was adapted from this article that was published by Jeannie Siegler a couple of years ago that gave some examples of the consultative care models for older people with HIV. I'm not going to read through all of them. It's just to give a flavor of the types of things that are done. So some of them involve the use of a pharmacist. Others have a geriatrician that sees referrals as needed. Some are embedded within the clinics and HIV clinics, and some are not. I know that Dr. Taylor is going to talk about the Golden Compass model, so I'm not going to spend time on that. And then again, some examples of the metabolic clinics. And I think increasingly people are interested in ways to incorporate e-health or mobile health or online supports to increase access to perhaps more personalized care, or care that doesn't require leaving the home for older people living with HIV. And I think we're probably going to see more of that now in the post-COVID world. I think the advantage of the geriatric consultation is really the geriatrician and the expertise that they bring, and that sort of more 50,000-foot view that the geriatricians have that oftentimes the specialists, including infectious diseases specialists, lack. The disadvantages, I think, really are that many of the tools that the geriatricians used are designed for much older people. And so if you're talking about somebody living with HIV who's in their 70s or 80s, this may apply. But if you're talking about somebody in their 50s, that may be a very different situation. And those screens and those tools really may not be applicable to somebody who's several decades younger, despite the fact that they're at risk for age-related conditions prematurely. And then the other issue is, and this is true for any consultation, you give recommendations, but you're not the person implementing them. So oftentimes those recommendations may not be acted upon. The advantage for the metabolic clinic is really you're the one implementing the protocols rather than any outsider. But the disadvantage is it tends to just be more of the same. It's essentially what's been going on in many places already. And that is, really focusing on each individual comorbidity. And then you have a pile of comorbidities with a pile of medications to treat it, and not really focusing on the bigger picture issues, and oftentimes with less focus on psychosocial needs. So we were funded through Gilead through the HIV/AIDS positively grant mechanism. We really were interested in developing our own HIV-specific comprehensive geriatric assessment that we could then implement in a multidisciplinary manner in our own HIV clinic, Montefiore's Center for Positive Living. And we already provide multidisciplinary care. We already have a lot of resources such as nutritionists and mental health providers and social workers. And so the idea really was that kind of what we used to do for the annual HIV visit could be retooled to do an annual geriatric HIV visit. And the idea is really that once this grant ended, the program would continue, because otherwise we haven't really benefited the patients that we care for. So the model really is designed to be sustainable and also scalable, and also to be utilized in places where you don't have access to a geriatrician. Because across the nation, we're seeing that the geriatric workforce is shrinking as the population of older people, and in our case, older people with HIV, is growing. And so that combination of both of those factors means that in most parts of the country, there just isn't a geriatrician available. And I can say for our clinic, we are a large volume HIV specialty clinic, and we can't send all of our patients to the geriatricians. They just don't have the capacity. So we have to improve ourselves. This is a table that just kind of shows what the components of a comprehensive geriatric assessment are. As you can see, it's quite exhaustive. Oftentimes the HIV providers don't really have the time to go through all of this, or the knowledge to know how to do these assessments or what they mean. We're good at focusing on comorbidities and HIV treatment and even preventive care such as vaccines and colonoscopies and things like that. But we don't do these kind of systematic assessments for geriatric conditions. And so as a result, I think, being more systematic and routinizing this could lead to the identification of problems that would otherwise be overlooked in a standard medical visits. Because many of these geriatric syndromes or these issues, impairment and functional and cognitive impairment, are not going to necessarily be reported. You're only going to find them if you look for them. And so what we did was we started with enhancing provider skills in aging-related principles. We needed people to understand why we're talking about this, what a comprehensive geriatric assessment is and what's included in it, and why those assessments are there and what they mean. What do you do when you find something wrong, and then to give a pathway for the providers. So these are a series of aging-focused lectures that we gave to the AIDS Center Grand Rounds. The AIDS Center Grand Rounds at my institution involves all disciplines. So it's everybody who's in the AIDS Center, all different. It could be people that are adherence counselors. It could be the medical doctors. Anybody and everybody in between. And then we're also working with a social work consultant on a social worker focused lecture series, but again, to include all disciplines, because I really think that this is for everybody. So talking about social support and loneliness, advanced care planning, aging services, and resources for age-friendly health. We also have been reaching out to our patients who are over age 60, reaching out and doing telephone surveys to understand what their priorities are, what their needs are, their met needs and unmet needs, what they would like a program to look like if they were able to design it, which they should be helping design it, helping us design it to serve their needs. And then in addition, a series of focus groups, one-on-one in-depth interviews, and then we have specific sort of target populations that are of great interest: cisgender and transgender women, MSM, people who inject drugs, and all of these are being conducted in both English and Spanish language. And then for our Center for Positive Living providers and staff, there's been a series of discussions with leadership, again, all levels: administrative, medical, nursing, social work, because everybody needs to be involved. This really is a team effort. A town hall to really get input on what providers see as the barriers to delivering quality care for older people with HIV and what their suggestions are. Structured surveys for providers and staff, including assessing issues of bias in these surveys. And then we're planning on doing in-depth individual interviews across all of the disciplines within our clinics. So initially, when we conceived this, it was really meant to be delivered in person. The patient would come in and they would see each different provider. They would sort of go room to room. They would meet with the nutritionist, the social worker, the nursing, kind of like what we used to do for the annual visits. And then COVID hit, and that just really wasn't possible. We really couldn't have people for many, hours in the clinic. Nobody really, the patients didn't want that. The providers couldn't do that. We couldn't have the space for the distancing. It just wasn't really feasible in that way. I know a lot of places have tried to utilize video visits. I will say that in our clinic, the uptake for video visits has been pretty poor. I think people prefer coming in still. And so what we decided to do was to take a step back and to actually start smaller and actually start with the higher end of the age group. We decided to really go for the age 65 and older group because we thought that group was going to have the greatest need and that the assessments were going to be the most likely to uncover issues that we could then impact. A lot of the people in care in their 50s are facing, a different set of issues. And there is obviously a huge diversity of experience, but we sort of figured this was going to be our first effort, and then we can always expand the age downward as needed. We also decided to start with a few providers and try and work out the kinks of doing these assessments. And then instead of starting by developing our own assessment, to use existing templates, and then as we get the feedback from patients and providers, and as we gain experience with it, we would revise it based on what then we uncover. And so we decided to go with the Medicare annual wellness visit as our initial geriatric assessment. And this slide just kind of shows what the different components are for the annual wellness visit. The goals of this visit in general are health promotion, detection of disease early, and coordination of screening and preventive services. This is something that's available to people who enter into Medicare and 1 year later and on an annual basis. And so, if people without HIV can have this, why can't people with HIV? So these are the required elements for the annual wellness visit. I'm going to go through some more detail on it.
I just want to be sure that Dr. Taylor has some time to present too.
Okay, so I'm going to skip this part. Just want to add that at the end of the annual visit, you develop a personalized preventive plan of care with the patient. So we've been working with our geriatricians. We've been trying to start up these annual wellness visits. It then develops a plan with you that you sit down. with the patient and discuss moving forward. And then the last thing I want to just touch on are some of the lessons that we learned, because it's been a long haul. So I will say that it's been a real challenge getting buy-in. This is very labor intensive on the provider end and on every end. And so it's been a real process. So I think it's, I'll be interested to hear what Dr. Taylor describes for her process. She's been very, very integral to the development of this program. We worked together on it. So last slide here is really, I think all of these points have already been hit, but I think we have to think beyond the standard T cells and viral loads and think about quality of life and connections to communities and, preserving function and independence over the lifespan for older people with HIV, and to get the input of our older patients when we design these programs. So I'll stop there. Thank you. You're muted, Tonya.
Sorry, as I get my slides together here, I just wanted to say that Dr. Karpiak is actually my mentor, and he was very, I think, a little humble in terms of not expressing sort of his profound impact on my career. And so I just wanted to acknowledge that. And also acknowledge my incredible partner in crime, Dr. Anjali Sharma, who I learned so much from Dr. Sharma, and indeed we are trying to work to get this, to figure out how we can, I like in your slides, you called it to geriatize primary HIV care. So today I actually have the pleasure of talking about a program that I will be implementing. So similar to Dr. Sharma, I developed my own program. However, I've been really lucky to receive an award from DOH to implement this new model of geriatizing primary HIV care. And so the name of this program is Building Equity, Intervening Together for Health, Be Into Health program for older people living with HIV. Of course, my first slide never advances. I just wanted to acknowledge that I am also a co-director of the BRIDGE program, which stands for Brooklyn Initiative to Develop Geriatric Education. If anyone is interested in free CME classes, I just learned that we don't really advertise it well, but anyone can take them for free, so please do reach out to me. This is our funding source. I have no conflicts. And what I'm going to try to do today is I'm going to try to succinctly just summarize what this program is endeavoring to do in terms of bringing geriatric principles into primary HIV care, talking about its components, its goals, objectives, and to also talk about its the evidence-based model that precipitated this. As Dr. Sharma mentioned, the truth is within primary HIV care and aging, we follow 5 M's. This is the age-friendly healthcare model that applies to, can apply to everyone, although we believe that with HIV care there requires another M. And the 4 M's include what matters, medication, mentation. I absolutely prefer Dr. Sharma's just focusing on the mind. Mentation is cognitive function as well as mental health and mobility. I just wanted to highlight this just to say that sort of this is really our ultimate goal, is to try to transform HIV primary care into an age-friendly healthcare clinic. I had an accident yesterday, so I'm really grateful that the people at DOH have allowed me to use some of their slides today. And so I just want to acknowledge, I'm not sure if you can see at the end, that these slides were actually designed by NYC DOH. Okay, and I want to emphasize that there are a number of Be Into Health programs that focus on different priority populations. Our particular mechanism is focusing on minority and ethnic older adults with HIV. The goals of this Be Into Health program are to first improve linkages to HIV care, to improve IART among priority populations. Those are individuals who knew that they were positive but have just been slow to engage in treatment, to improve overall engagement and re-engagement into HIV care, improve retention, to improve viral load suppression within among older adults with HIV, and to strengthen the capacity of our HIV clinics to provide tailored, and I would have modified here, geriatric services to our older adults with HIV. Dr. Sharma is correct that there's been this arbitrary cutoff in terms of us thinking of an older adult with HIV starting around 50. But I think that it is important for us to start thinking that it could start as early as 50, but usually around 65 is when we see sort of a combination or a clustering of issues, and perhaps maybe that advanced age within HIV is the group that we will probably make the most impact. I wanted to just outline here what the objectives are. So we're also trying to increase or try to find older adults that are newly diagnosed. Also try to bring back individuals who were previously diagnosed, re-engage, as mentioned, retain, viral load suppression. One of the key objectives in this program is to increase screening for, and I just want to add that everything in bold red are words that are mine, and that the remainder of the slides are actually DOH. So the language is increasing screening for older people with HIV, and I would emphasize that these are specific geriatric screens, to increase successful geriatric referrals, to decrease rates of depression, and to increase quality of life. There is also a very specific goal to increase regular physical activity in group, and also to increase social activity through social engagement projects, and both of those are monthly. And then finally, the ideal goal is to create not just multidisciplinary but interprofessional care coordination with our older adults living with HIV. I made this slide, which basically outlines clearly what are the activities. So we will be looking for new clients, those who are coming back in, those who are newly diagnosed. Our major activities include biannual STI and Hep C screening and treatment if needed, a biannual geriatric assessment, and these are some of the key measures that we will be using or focusing on. The creation of a geriatric care plan, and we will have monthly case management meetings and monthly case conferencing to hopefully provide information to the broader clinic about this geriatizing primary HIV care. As I mentioned, there is we will be doing monthly physical and social activities. Most of the social activities, both will be group, and a number of the social activities will be for fun and some will be educational. Also, we have a number of evaluation activities to make sure that we're achieving our project outcomes. I think I might skip these indicators because they're clear, I think. What I'd like to now discuss quickly is that this initiative, the Be Into Health initiative, stems from an evidence-informed model that was developed in the West Coast by our colleagues UCSF in San Francisco, and this model is called the Golden Compass. And the Golden Compass program is it's a comprehensive care program for people living with HIV over 50, and it focuses like a compass on it has sort of 4 different points: north, south, east, and west. I just wanted to mention that the staffing for the Golden Compass intervention initially included all of these particular providers, which is a little heavy in terms of a sustainable model. I just wanted to say that with the heart and mind, this is the north point, that they focus on cardiovascular outcomes and cognitive evaluations, or focusing on that mind M. For the East Point, it was on bones and strength. And for the West Point, it focused on dental health, hearing, and vision. And then for the 4th point on the compass, networking and navigation. So this was social engagement as well as navigation, to make sure that individuals who needed extra help with adherence or other aging-related accessing other aging-related entitlements were able to receive help. I'm going to jump over this because I do realize I don't have as much time. I want to mention that sort of in the original Golden Compass, they did have group classes. It was called a wellness club. And I think that having an educational group activity is really key to sustaining the intervention and the impact, in terms of allowing the clients to have multiple moments to be exposed to thinking about how to age successfully. Again, in San Francisco, there was a focus on cardiovascular consultations as well, and they had a weekly consultative geriatric clinic. So weekly they would do these assessments, and I would imagine with probably linking it to their annual review. These are the duration. The wellness club lasted for about 50 minutes, and it was bi-monthly, or I'm sorry, it was weekly over 2 time periods. There were also brain health classes that were a little bit longer. They were 2 hours long, and they were conducted through 3 different series over 9 weeks. The cardiovascular consultation were as needed, and these consultations existed twice a month. And then finally, as I mentioned, sort of the weekly geriatric consultation with HIV expertise was every week, and each session was scheduled for 60 minutes. For the evaluation, they used the re-aim to evaluate the effectiveness of their intervention. So from January 17th to about June 2018, they recruited 198 adults. All of them were over 15. And they estimate that their overall reach within the clinic was about 17%. Providers and the patients all indicated a high acceptability for the program and were satisfied with the clinic classes. The co-location of services, specifically the pharmacy and the geriatric assessment, were valued in the fact that it became almost a one-stop shop. The provider adoption was high, and this is something I think that is unique, because as Dr. Sharma has mentioned, trying to get build-in or buy-in has been somewhat of a challenge here in New York City. I wanted to just also highlight some best practices suggestions that were really effective. One was around recruitment and the use of framing the language around this particular study in terms of staying healthy as you're getting older, or living longer with HIV. I think in our clinic, as we refer to it as healthy HIV aging, but this reframing of what is happening to allow people to understand sort of the long-term trajectory of what this goal is ultimately about, as opposed to just a couple of assessments, that it is a long-term process. The co-location of services was enormously valued. one client said, I wish I can have all of my appointments here. I'm familiar with the building. I still show up, but it's just more far away and it's different. So I got to plan my timing and stuff. And this is in regards to her or his or her other appointments. Access to the co-located geriatrician was maybe difficult in some settings due to the limited number of geriatricians, and that's why I want to emphasize programs such as the Bridge program, where we are trying to work with providers, whether HIV primary care, nurses, PAs, anyone, to basically add on to their skill sets some of these key skills and training to be able to implement this into their care practice. I realize that I'm running out of time, I think that Dr. Sharma is correct in the fact that some of these assessments are applicable for individuals, but if you focus on the chronological age, there might be a younger, less at risk HIV positive group, and that sort of as the cohort within these clinics, that maybe the assessments, the full battery of geriatric assessments might be it might be more appropriate for the older patients in our clinics. I want to mention that there are a number of really wonderful resources that have been developed by HRSA in terms of putting together the best health team. The language within an age-friendly healthcare system is interprofessional as opposed to multidisciplinary. Just want to emphasize that. And that also this wonderful pamphlet talking about incorporating new elements of care into HIV care. There's there's a New York State guidance on needs for older people with HIV, and AECT has also developed an Aging with HIV toolkit. I wanted to mention, just like Dr. Sharma, I tried to figure out how to geriatrize HIV primary care in my clinic. I developed in collaboration with Michelle Lopez this intervention called The Change, which focuses on healthy HIV aging for women. And our primary hook, in addition to talking about just healthy aging, was to also talk about sexual health and aging. So we focused on menopause as this particular biologic event that happens that unfortunately women with HIV and without, that we really don't get the space to be able to have these conversations. It was a real powerful hook, and it was well received. Within this intervention, we focused on strengthening components of resilience, emphasize sustaining a viral suppression, which is key to aging successfully, being proactive in terms of self-care management, especially with multimorbidities, trying to, even it's not too late to quit smoking or whatever, to reduce certain lifestyle risk behaviors, and a huge emphasis on social engagement. We developed this intervention. It has 4 sessions, each are 45 minutes long. The formats include individual, group, and we are now currently developing virtual learning modules that will also be done one-on-one with the clients with a navigator. And these are the 4 sessions that we developed. I'm hoping that I did justice with describing the Golden Compass. Golden Compass, this is an enormous opportunity for us to test, pilot a very streamlined way of geriatizing primary HIV care, so that both well-resourced and clinics that are not as well-resourced will be able to have a roadmap to be able to successfully bring in these geriatric care principles and be able to hopefully take our patients, our older, successfully aging patients, to help them improve their quality of life as they age. So I just want to thank folks, and I don't know how I've done on timing.
It is 3:31, so that is great. Thank you so much. I also, just so folks know, I just put the link for the evaluation of this webinar since we are coming to a close. That's the SurveyMonkey link. I'll post it again. And yeah, I think please do fill it out. It only takes a few minutes. It allows us to prepare better, to absorb feedback. The feedback that we got last year was really valuable for this year. So it will continue to be as we continue to do this. And we're also doing a training. It will be facilitated by me on Monday at 2 p.m. Eastern time. I also have that Eventbrite link in the chat. There's no charge. It's how to support LGBTQ plus older adults. And that we do incorporate kind of including folks who are aging with HIV, because sometimes there is that overlap. And then I also have this additional resource up right now, just if you would like to kind of learn more about the work that we do at the National Resource Center for HIV and Aging, GMHC, the work that we do, including the Brene Booger Hub that Greg Burkno talked about during the previous panel. We also have Let's Kick Ass, which is a really great group. I know Jules is here today. And there's a couple of organizations, including, for instance, OWL, which Melanie Reese is the executive director of. If you know of any other places serving people aging with HIV, please do let us know and we can get that info out. It looks like we just have one question in the chat. So if folks want to, just stay and hear it, then we'll wrap up. So it says Jeff Taylor says the MACS WIHS combined cohort is an amazing resource, but it's limited in being, just observational. Intervention trials are not allowed by their funding, but at the same time, getting aging research done in NIH funded groups like ACTG has been pretty difficult. Any suggestions for getting around these obstacles so that we can do this really needed research?
And with ACTG, in terms of trying to,
I think it seems that person wants to know how do we get around the obstacles of getting aging research done in NIH funded groups like ACTG.
I just want to say that over and Dr. Sharma and Dr. Karpiak can attest to this, because I think I submitted 5 grants, I submitted 5 times a grant to basically.
Oh, sorry. Jeff just said NIH in general, but specifically ACTG. Just wanted to clarify. Sorry to interrupt.
Well, what I was trying to say is that I think that over the last couple of years, this has not been a priority. And that has really been a detriment in terms of trying to allow, with the ACTG and others, review groups to be able to think about funding some of these models. I'm hoping that with this exciting work in San Francisco and here in New York, that NIH will once again move away from biologic outcomes or foci, and we'll come back again to thinking about care and care models and supporting what I'd like to think of as sort of applied HIV and aging research. Dr. Sharma?
Yeah, I think, well, a few things. I mean, so Jeff's right that, the Max-Wise combined cohort study is an observational cohort study. So it's not a clinical population, and we don't do interventions. So we just observe what happens with people over time, and it's been so valuable over the last 40 years. But I think for a lot of things, when you submit these applications, they say, but what are you going to do? Like, let's get something done. So if you want to do an intervention, that's not the place for it, but there are lots of places for that. And I think that's where the clinical population comes in. because I think also a lot of interventions depend on the local context, so there are, and then, for us, like actually this Gilead program was fantastic. It provided 3 years of support to to do this program and many different programs across the country as well. And then they just had put out their call to renew it. So there are foundations and there are, places like that. But I think I agree that it's been kind of disappointing to see that the NIH pay lines for aging, National Institute of Aging pay line is really pretty poor. But that's kind of different than care delivery. I mean, I think there are a lot of different interesting studies that need to be done. As Dr. Taylor was mentioning, it sort of involves, a little bit of a masochistic, bent you have to just get, put in so many grants to get one funded, and there was an RFA there is an RFA on multidisciplinary studies of HIV and aging. And it is to really, it's pretty broad in the types of things that they're interested in funding. We just did an application in September to look at cognitive control of gait, because HIV does impact the mind. There's a systemic inflammation from HIV that impacts cognition, which can then lead to gait disorders. And so we were sort of interested in disentangling that. But I think that it hasn't been as much of a priority. I think the entry point is the comorbidities in terms of the HIV research priorities from the NIH, which isn't exactly what we're talking about, right?
Yeah.
Yeah.
And my comments were really very specific around intervention studies. As an interventionist, over the last maybe about 5 or 6 years, it just seems like behavioral interventions based in the clinic were not a priority.
Yeah, and I think both. We need both of these things, right? We need NIH research, and I think, as was mentioned earlier, we need women and minorities, and we need impacted populations to be involved in that research. And then we also need innovative models of care delivery to deliver the care. I think one of the big challenges that we had for our program was even, we had slotted 40 minutes for these visits, because that's what we would get for an annual visit. And it was not nearly enough time. So to look at that Golden Compass model, to have 60 minutes, but to have all of the supporting resources with a nurse, pharmacist, and your own geriatrician, I mean, that's just not something that, we can afford to do. But, I mean, I look at that and I'm like, I'm jealous. I want all of that, for my patients,
All right, thank you all again so much. I really appreciate all of the panelists presenting today. And for folks attending, I know Zoom fatigue is very real, so we really appreciate you coming. Again, I just put in the chat really quickly the Survey Monkey. Again, it only takes a few minutes. Please do give us some feedback, comments, complaints, whatever you got. And again, the Eventbrite link is for a training about how to support LGBTQ older adults in your work. And again, we do incorporate people aging with HIV in that. So please feel free to sign up for that. It's from 2 to 3 on Monday. There's no charge. And yeah, thanks again, everyone. Have a great rest of your afternoon. Oh, Dr. Sharma, Dr. Taylor, people are asking if it's okay if they can get a copy of your slide decks.
Yeah, what's the best way should I just send them to you and then you can distribute them?
Yeah, I believe I have them, and I can send them out to folks who registered for this webinar. I know Mark.
Meredith, I just have to remove one slide from mine.
Oh yeah, no problem.
I'll send a revised one, okay?
No problem. Yeah, I know folks have been asking a lot. Again, we are going to release a recording on the NCHRA site. I believe, Mark said that he is okay with it. I think the only kind of person, Director Phillips last year when we had Dr. Fauci, he did not permit us to send the slide deck. I would imagine it might be the case here too, but that being said, again, we are releasing a recording of the webinar, so the slides are available in that format. You can go back to them in that way.
Thank you.
Before we go, I forgot to share my acknowledgement slide, and I just wanted to just acknowledge a few people, which is I wanted to acknowledge, first of all, Dr. Taylor, who's
Right back at you.
My partner in crime. I'm so grateful to be able to work with you, Tonya. And then Dr. Karpiak, who really has pioneered a lot of this work. And I really want to also acknowledge Michelle Lopez and Jules Levin for their just tireless advocacy on behalf of older people, living with HIV. And I learned so much from you guys. So I just wanted to say thank you for that.
It's
Thank
amazing.
you. Thank you, Anjali, for thanking everybody, because that's really important. We would not be able to do this work without sort of the pioneers who came before us, Dr. Karpiak, Mark Brennaning, Dick Havlick, etc., but also without Michelle, Jules, and others who've taught us what's really important. So thank you.
Wonderful. Yeah. So again, I hope everyone has a great day. I know folks are starting, to trickle out, which is totally fair because we did just end the webinar after going just a few minutes over, but I'm just going to keep it open for another minute or two in case folks have anything
I have
else
to
to
skedaddle, but
All right,
thank you,
take
everyone.
care.
Would you like me to stop the recording now?
Yeah, I think we can do that. It seems like folks are heading out. So I'm just going to end it. Again, thanks for attending, everybody. Have a great day. We will be editing this and dividing it up by individual presentation. It'll